Welcome to new 2021 USPSTF lung cancer screening recommendations. What, why, and next steps. My name is Merlene Tucker, and I'm here with my colleague, Jeff Bornstein. Together, we'll be running this Dialogue for Health web forum. Thank you to our partners for today's event, the Luca National Training Network, the University of Louisville, and the Bristol Myers Squibb Foundation. Now, it's my pleasure to introduce today's moderator, Celeste Worth. Celeste has over 20 years of experience in cancer control and provider education and is the director of the Luca National Training Network at the University of Louisville. She is also a tobacco treatment specialist and master certified health education specialist. She was previously a co-investigator for the provider education component of the KY Leads Collaborative and the professional education and training manager for the Kentucky Cancer Program at the University of Louisville. Celeste has also co-authored a book chapter on tobacco use and control in the soon-to-be-published Lung Cancer: New Standards of Care. Welcome, Celeste.
Hello, everyone. So happy that we had an outstanding response to today's webinar event with such a timely topic. I am so thankful for all of you who could make it. I will happily announce that we set an all-time record with having over 1,000 people to register today for today's event. And we really look forward to sharing very exciting information with you with our expert speakers. Right, for those of you who are not familiar with Luca National Training Network, very quickly, we are based at the University of Louisville in Louisville, Kentucky, and we are the only organization that focuses on provider education and training surrounding lung cancer care. And so due to time today, I won't go into details, but please contact us, take advantage of our services. I'll be mentioning a few special resources later on in today's event, but we are happy to provide all of our offerings that are for education and training, as well as other resources and tools and technical assistance free of charge. We are celebrating our 7th event in a lung cancer care webinar series. So we encourage you to visit our website to check out the recordings of the previous webinars that have taken place, and feel free to share those with others, and there's easy access for that. And I want to then just jump into our introduction with our esteemed speaker that is a renowned expert on the topic that's being covered today. Let me start by saying that I'm very fortunate to have known Dr. Kazerooni since the first year that I and Luca National Training Network joined the National Lung Cancer Roundtable, and she has been a go-to expert for us ever since, and fortunately is also a member on the Luca advisory panel. But to give her formal introduction, Dr. Ella Kazerooni is a professor of radiology and internal medicine at the University of Michigan in Ann Arbor, Michigan, specializing in lung disease, including lung cancer. Her work in lung cancer screening includes serving as site principal investigator for the National Lung Cancer Screening Trial, the inaugural chair of the Lung-RADS interpretation schema for reporting and managing lung cancer screening CT exams, chair of the American College of Radiology's Lung Cancer Screening Registry, and a partner in advocacy efforts to move forward lung cancer screening implementation. Lastly, she is chair of the National Lung Cancer Roundtable with a mission to create lung cancer survivors. So with that, I will stop sharing and turn it over to Dr. Kazerooni for her presentation.
Great. Thank you, Celeste, for that wonderful introduction. It is my pleasure to be here with you today, and we'll get right into the meat of the matter. So I'd like to share with you the updated 2021 USPSTF lung cancer screening guidelines. What is this recommendation? Why have the changes been made? And importantly, what are next steps and implications for practice? It's great to be joined today by Efren Flores, my colleague from Massachusetts General Hospital, who will follow on. And what we really need to focus on is implementation to reach diverse populations for which lung cancer screening is appropriate. I have no financial disclosures. So I'll review the history of the USPSTF guideline, the 2013 guideline, which was the first to include low-dose lung cancer screening using CT, and the current updated 2021 guideline that came out just last month. What are those next steps for implementation, and what does it mean for reimbursement so that patients can receive the service? The first USPSTF lung cancer screening guideline was published in 1996. Screening is a test that is recommended for people who are asymptomatic for the condition for which we're screening. And at that time, routine screening was not recommended with currently available technology such as chest radiography or using sputum cytology. The next update, 8 years later in 2004, again, did not find any evidence to support a way to do lung cancer screening. As we know, lung cancer is the leading cause of cancer death in the United States, responsible for more mortality than cancers of the breast, colon, and prostate gland combined. The first USPSTF lung cancer screening guideline to recommend the use of low-dose chest CT came out at the end of December 2013, recommending low-dose CT in individuals aged 55 to 80 years of age with a 30 pack-year history of smoking or greater, who are either currently smokers or those who quit within the past 15 years. They recommended that screening should be discontinued once a person has not smoked for 15 years or develops a health problem that substantially limits life expectancy or their willingness to undergo curative surgery. They published their guideline-based recommendations and the reasons behind that guideline in the Annals of Internal Medicine. A grade B recommendation, which was given at the time and continues to this day, indicates that either a screening test has a high certainty of net benefit that's moderate, or moderate certainty that the net benefit is moderate to substantial, that this service should be offered or provided. Why is a grade B recommendation important? Because according to the terms of the Patient Protection and Affordable Health Care Act, this requires private payers to cover this without a copay. So with this coverage decision in December 2013, lung cancer screening by de facto is required to be covered by private payers. This does not apply to populations such as the Medicare population or those in populations such as covered by the Department of Defense or some other capitated systems such as the Veterans Health Administration. In the fall of 2013, Medicare received 2 requests for a national coverage decision, and they finalized their coverage decision in February 2015. So with this, we now had coverage for private payers as well as through Medicare beneficiaries. There were, however, concerns with the 2013 guideline. In particular, that it undercounts African American individuals who are more likely to start smoking at a later age, who might smoke fewer cigarettes per day than Caucasians who smoke, have a longer duration of smoking, are less likely to quit and have a higher percent that are current smokers than whites, and tend to be diagnosed at an earlier age despite advanced stage with high risk factors, even after accounting for levels such as socioeconomic status and other risk factors. The National Lung Screening Trial only had 4% of its individuals in that trial performed in the US who were African American individuals who smoked. Other concerns are that the prior guideline doesn't use any individual's total risk for lung cancer. As we know, there are other risk factors for lung cancer beyond cigarette smoking combined with age. Those include occupational exposures, radon exposure, family history, and many underlying lung disease among them. The 2013 guideline also does not address individuals who never smoked. However, for that population, there is very little data to support lung cancer screening currently in the United States. You may have heard of a trial conducted in Taiwan, a country where there is a high concentration of kitchen gases in cooking that may contribute to risk in that country for individuals who never smoked, as well as there potentially an underlying high genetic risk. But there's no data in populations such as ours that never smokers should undergo screening currently. This is a subject, however, that needs active investigation. We do have data about lung cancer screening in African American adult smokers. And this study by Aldrich et al. From 2009 evaluated the accuracy of the prior USPSTF criteria in a predominantly African American and low-income cohort. Adjusting for age, smoking history, African American ever smokers were at higher risk for cancer than white ever smokers. Yet a smaller percentage of African Americans met the USPSTF criteria than whites. In their analysis, lowering the payor criteria to 20 payors was associated with increased screening eligibility of African Americans with equitable performance. Their conclusion was that the 2013 USPSTF guidelines may be too conservative for African Americans. Another study looking at this issue, also published in 2020 by Pasquinelli and colleagues, looked to determine if the PLCO lung cancer risk prediction model could more efficiently select African American ever smokers for screening than the prior USPSTF criteria. Looking at 883 ever smokers, they concluded that the model increased sensitivity for identifying African Americans at cancer risk thresholds that would be warranted. So here we have two pieces of evidence that the USPSTF 2013 criteria were too conservative in the African American population. These are the references for those two articles if you're interested in going into greater detail to understand their methodology and additional components of their analysis. So how does the USPSTF go about its process? It develops a draft research plan for what needs to be looked at, which is put out for public review and then finalized. It then takes that research plan and executes it, which may include analysis of data as well as published literature, to develop a draft recommendation through a process of evidence review. That draft recommendation is an opportunity for comment, and the current lung cancer screening guideline was put out for public comment last summer. Based on review and incorporation potentially of comments that are made, a final recommendation is made with evidence summary. The AHRQ provided the evidence synthesis for the new USPSTF guideline and is available online, looking at 223 publications and 7 randomized controlled trials. What's new for 2021 from the evidence review performed by AHRQ and reviewed by the USPSTF panel? The USPSTF evidence review, as well as the summary of its decision-making, is now available in publication in JAMA. Screening high-risk persons with low-dose CT can reduce lung cancer mortality and may reduce all-cause mortality, was their conclusion. But they cautioned it can cause false positive results, leading to unnecessary tests and procedures. The identification of incidental findings that need to be managed, potentially short-term increases in distress from things such as indeterminate results, and rarely radiation-induced cancers. The evidence of benefit for lung cancer screening largely comes from 2 randomized controlled trials, the National Lung Cancer Screening Trial in the United States and the Nelson study in Europe. These were mainly conducted at large academic centers, but we know that many of the centers, while academic, had community-based practices involved in patient recruitment. They noted that the application of lung cancer screening with current nodule management protocols, such as lung-RADS, might improve the balance of benefits and harms, noting that lung-RADS reduces the false positive results compared to NLST data, and that using lung-RADS would have prevented about 23% of all the invasive procedures for false positives that were seen in NLST. They also stated and discussed the issue of risk prediction models, like the PLCO model, noting that while they might improve the balance of benefit and harms, there remains considerable uncertainty about how such approaches would perform in actual clinical practice, because current evidence has not included any prospective clinical utility studies. So where did they land on their new recommendation? It remains a grade B recommendation based on the 2 randomized controlled trials and additional modeling data. The change from the prior guideline is that the lower age band has been reduced from 55 to 50 years, and that the payor criterion reduced from 30 to 20. What does this mean? This doubles the number of people eligible for lung cancer screening in the United States. It means that many more African American and female smokers will be eligible, because the data shows that African American and women tend to smoke fewer cigarettes than the general white Caucasian man. but African Americans have a higher risk of lung cancer than white people at the same level of smoking history and at lower smoking histories. Some quotes from the USPSTF panel members themselves. New evidence provides proof there are real benefits to starting to screen at a younger age and among people with a lighter smoking history. We can save more lives and help people stay healthier longer. Some really good news from changes to this recommendation is that it will mean more people are eligible for screening, including notably more African Americans and women. Making screening for lung cancer available to people who have smoked less over time will help doctors support their health and potentially save lives of more of their African American and female patients. Well, what next? What are the payer implications? These changes from the USPSTF in 2021 are immediately effective, but the reality of the change is linked to coverage. While some people can afford to pay for lung cancer screening out of pocket, many cannot. With the linkage to the Affordable Care Act, it does require private payers to cover lung cancer screening using the updated eligibility criteria within the next 12 months in accordance with the date of their contract renewal cycles. So it can take up to 12 months. That's a bit disconcerting because we'd like to see them effective immediately, but the reality is we have to work on coverage. A formal request has been made to reopen the Medicare National Coverage Decision in a joint letter from the American College of Radiology, the Society of Thoracic Surgeons, and the GO2 Foundation for Lung Cancer. Therefore, Medicare will be reopening its national coverage decision and may now consider the information that was available in evidence review and synthesis from the USPSTF, as well as other data on all of the NCD requirements. But what can you do now if you're frustrated that you have to wait for the CMS NCD to be reviewed or for contract renewals in your area from private payers to overturn? You can advocate now to your private payers to make the changes earlier. We've already seen evidence of some private payers making the change shortly after the USPSTF made its announcement. You can also begin to advocate now to your state agencies overseeing Medicaid services. Medicaid service decision-making is based at the state level. It does not follow the private payer requirements of the Affordable Care Act or the CMS NCD. So you can make a difference now by advocating based on the new information that's available from the USPSTF. As a bonus, something that was a press release came out this week from the American Academy of Family Practice. They have now updated their lung cancer screening guideline within less than a month of the USPSTF publishing their updated guideline. The American Academy of Family Practice now recommends lung cancer screening with their grade B recommendation for the same population that is recommended by the USPSTF. Their prior recommendation had been indeterminate, as there was only one randomized controlled trial at the time. So together with a USPSTF change in coverage, change in recommendations for the guideline, now helping us reach twice the number of people potentially who are at risk for lung cancer, the American Academy of Family Practice guideline has followed and should help propel us further into strong implementation. I want to thank you for helping to create lung cancer survivors. By being here, this shows your interest. We want to lower the impact of lung cancer through prevention, early detection, and the assurance of optimal therapy that follows, and to do so in a patient-centered, evidence-based manner that's inclusive, diverse, proactive, and visionary. You are visionary and proactive in participating in this LUCA webinar today. And I want to thank you for your participation and your commitment to creating lung cancer survivors through screening and early detection.
Wow, that was wonderful, Dr. Kazerooni. Thank you so much for that information that a lot of people have been waiting quite a long time to hear. There's been a lot of relief about finally getting the USPSTF recommendation, but also I think that the news of the AAFP recommendation was news to a lot of people today. And so we've got them going hand in hand with a great benefit. If you weren't already familiar with our online course for CME CE credit, it's called Lung Cancer and the primary care provider. This has been available on one platform, but is now available on two. It's very innovative in that it's mostly video based, not a lot of reading involved, so we keep it interesting and interactive. And in addition to the CME credit for physicians, there's also FP credit with the AAFP prescribed credit, as well as credit for nurse practitioners. And in order to make this even more accessible for those who are aware of another platform, we have made it available on there as well. And that's in a partnership with the American Medical Association, their AMA EdHub platform. And so it's very easy, again, to take this for free. It's up to 2.5 hours of credit. It can be done in 3 separate modules. And the nice thing is you can come and go to whatever point you left off and get any type of credit, even though it's on AMA's site. And we encourage you to go there, check that out, and take advantage of sharing the information for those who are interested in a more deeper discussion, a deeper dive into what's being covered today. We are currently making those updates about USPSTF and AAFP, but we will be constantly making other updates as well. So keep in mind that those 3 modules cover the entire spectrum of lung cancer care across the continuum. And we hope that you will look into that. We also just want to make you aware of one of our latest tools, which is an infographic, what every primary care provider should know about lung cancer. And that has already been updated with the new criteria. So feel free to go to our website at lucatraining.org to get a digital version of that to easily share with others as well. So that being said, I want to move right into introducing our next esteemed speaker, Dr. Flores. I've been fortunate to know him as well for the last few years with the national meetings that have taken place. And I'm very thankful to both of our speakers for their willingness to do this today. And also want to comment that Dr. Flores has been a big supporter, a big fan of Luca and all that we've been trying to do and sharing the word about our resources. So thank you for that again. Let me go on to say that Dr. Efren J. Flores currently serves as a board certified staff thoracic radiologist at Massachusetts General Hospital and is an assistant professor in radiology at Harvard Medical School. Dr. Flores is also a health services researcher focused on health equity and community-based participatory research. His research efforts aim to decrease disparities in lung cancer outcomes by increasing access to lung cancer screening among vulnerable patient populations. So with that, welcome Dr. Flores, and I will turn it over to you.
Thank you for the kind introduction and incredible presentation by not only Luca team, but also by Dr. Kazerooni as always. So I'm gonna share my screen and let's get started. So everything okay? So today I'm gonna talk about not only Dr. Kazerooni did a phenomenal job presenting what are the implications, not only the history of USPSTF criteria, but the implications on the new guidelines. And the way that we see these new updated guidelines is that it creates opportunity for lung cancer screening outreach, particularly among underserved patient population who have been severely impacted by COVID, as we've seen over the past few months. These are my disclosures. So I'm going to start with one of the specific, one of our patients' quotes during one of our focal groups in a study talking about trying to increase access to lung cancer screening among individuals with Medicaid and among Latino individuals. And this patient specifically said, how do you just go about asking a doctor to get a lung screen? And it really shows that our patients' needs guide our care. We have to try to understand the patient's perspective in order to advance equity in lung cancer screening and in the lung cancer continuum. So for example, in 2018, the statistics in lung cancer, we know that lung cancer remains the highest cancer, with the highest mortality compared to other cancer, including breast, pancreas, and colorectal. And those statistics have not changed dramatically, even though that we have incredible advancements in lung cancer treatment. Some of the statistics remain similar. So approximately 235,000 new cases of lung cancer being diagnosed and approximately 131 deaths related to lung cancer are estimated this year. But lung cancer doesn't affect everyone equally. Dr. Kazerooni talked about the impact on racial and ethnic underrepresented minority, particularly in the African-American community. But disparities are not only limited to racial and ethnic minorities. Also, as we can see here in this graph published by Dr. Siegel and his team, from data from 1970 to 2016, that regardless if among males and females, individuals that live in poor counties have a higher mortality rate compared to those that live in more affluent counties, and that's more marked among male compared to female, but still the disparity exists. So that just a proxy, what it let us know is that there are factors that are beyond language, beyond race, that impact how patients um, access care. And when we talk about lung cancer disparities, we know that these are mostly factorial. So there are societal factors, such as insurance coverage, socioeconomic status, environmental factors, exposure, environmental exposure or home exposure, biology, right? So there are some genetical factor and predisposition, smoking history as well, the length and intensity, but then also access to early detection. And that's where our work really is centered. Through lung screening, we have an opportunity to impact the cancer care continuum, because the best treatment for any cancer is early detection, as it gives patients more options for treatment and potentially curing. And Dr. Kazerooni did an excellent job showing the evidence about the benefit of lung cancer screening. So we know that early detection with annual screening has multiple clinical trials have shown the proven benefit on mortality reduction. Medicare and private insurance will cover lung screening, but still recent studies have shown that lung cancer utilization remains low. In the study published in Cancer from in 2018 using behavioral risk factor survey data showed that among those states that were participating in the study, even though you have a certain number of individuals that are eligible, still the individuals that are eligible and utilizing lung screening, that percentage remains low, between 7 and 20 to 30%. So there's a lot of room for improvement in lung cancer screening uptake to improve lung cancer outcomes through early detection. When we think about lower utilization rates in lung cancer screening, can help us think about some of the barriers that some of our patients face, particularly those that are most vulnerable. Those barriers can go from lack of awareness, cost concerns related to copay, even if it's covered by insurance or if the individuals are uninsured, access challenges, so they have access to lung screening facility, is the material to conduct shared decision making available in a language that they understand, is a readability level available for them, and identifying eligible patients using the medical record or proper documentation of smoking history in the medical record from the patient and the provider. But those barriers are not limited to that. If we take a deeper dive into them, a study from our team, where we looked at readability, evaluating readability levels of lung cancer screening websites in the United States. And we look at the red line, which demarcates the American Medical Association recommended grade level, 6th grade. We can see that basically all websites are above that level, and the median reading level was 10th grade. And health literacy is an integral component of shared decision making in any health decision. But is our information accessible for our patients? And more now than ever, that telemedicine have become so prominent in our healthcare delivery, and many people go to the internet to access healthcare information. We gotta ensure that we not only we have accurate information, but that information is individuals can reach that information so in a way that is understandable for them. Also, COVID-19 has impacted our the lives and livelihood of many across the United States, and that has impacted financially a lot of communities, particularly those were already in a vulnerable position. Many have lost their jobs, changed insurance, and so that creates a lot of concern about costs and costs related to their care. And in a study that we did published last year, with an analysis of out-of-pocket costs to lung cancer screening among accredited facility by the American College of Radiology, the average cost for out-of-pocket costs for those that don't have insurance would be approximately $583, in a range between $49 and $2,400. We think that a screening, lung cancer screening, and any cancer screening modality is for detection of asymptomatic disease, people that may be working 2 or 3 jobs at a minimum wage and struggling to put food on the table or paying their rent. They have to make a conscious decision about paying out of pocket if they don't have insurance for a study to let them know about an asymptomatic disease, or worrying more about pressing need to put food on the table, or making sure their families and their dependent ones have a roof where they live. And these are the decisions that many of our patients face. So when we talk about lung cancer screening, although we may think that is accessible, many face many barriers to care to make that decision to undergo lung screening as a starting point. But on top of that, if we think about the um, um, complexities navigating the healthcare system and barriers outside and within the healthcare system, such as mistrust, language barriers, cost concern, and stigma associated with smoking and lung cancer, you can see that making that decision to undergo lung cancer screening will almost disappear. It may be almost unattainable for many of them. And what those barriers do is that they break health healthcare provider and the patient relationship. So even if somebody is ready to undergo lung screening, when we have barriers like health literacy challenges, lack of awareness and cost concern, limited English proficiency, scheduling conflicts, and social stigma among other, what they do is create additional barriers to lung cancer screening, and maybe the patient doesn't want to undergo lung screening anymore. And we can't talk about barriers to care without talking about social determinants of health, which are the condition in which we live, work, educate ourselves. And those include neighborhood environment, access to healthcare resources, education, economic stability, and more so that have been being discussed more and more frequently, racism as another structural barrier. And although zip codes shouldn't predict how long you live or how you should be accessing the healthcare system, COVID have really made more evident that this zip code impacts how you access care. And this um, provides more than just barriers, is our opportunity for outreach for our patients, meet them where they are. And what we are moving towards in accomplishing in radiology through our race, equity, access, and community health care delivery transformation initiative to detect what are the barriers, understand them, using a lens of empathy to put ourselves in our patients' shoes, develop, integrate their input into our programs, and reduce disparities and continuously measure the effect to ensure that these disparities and these programs are addressing the disparities that we're concerned, but also improving the care for those that need it the most. Some of the things that we've done is overcoming language barriers for individuals with for Latino individuals. So, for example, translating our patient flyers into Spanish, but also making the language accessible in terms of readability level, and using more visuals as well to make it easier to navigate and comprehend. We've also launched digital awareness campaigns using Facebook, Twitter, Google, LinkedIn for providers and patients, where we did 20-week digital awareness campaign assessment to see visits to institutional lung cancer screening webpage and assess the impact on order exams before and after the implementation. And what we see that after the campaign, we see the effect that it was significantly increased number of lung cancer screening orders on these patients. So people are engaging, and now more, we should be leveraging telemedicine platforms to continuously engage patients and try to address some of their concerns. Also overcoming scheduling conflicts. So we are offering same-day lung cancer screening for individuals who are experiencing homelessness. And then also integrating lung cancer screening into screening mammography encounters. So we've added a survey to assess the patient's eligibility, and also if they are currently smoking, to see if they would like to, one, be referred to lung cancer screening, and two, if they would like to be connected with smoking cessation resources. And this is important because if patients are overcoming many barriers to get to one point in the healthcare system, it's our duty to try to offer as many resources as possible during that healthcare encounter. In this study, where we have approximately 1,900 people that responded, only 30% of those that were eligible had lung cancer screening, and 26% of those that were currently smoking were wanted a referral to smoking cessation. So it just shows the opportunities of engaging patients and meeting them where they are. Another patient population that we have worked with is those individuals with serious mental illness who die 15 to 30 years earlier than those without. And the second leading cause of that premature mortality is cancer. Usual care model for patients undergoing screening, that primary care leads cancer screening or any other health preventative services, and mental health is fragmented from the rest of the patient's medical care. And radiology interact with the PCP, but not directly with the patient. However, when we're proposing is a team-based approach to screening, where this becomes a shared responsibility, and where we aim to leverage the trusted relationship for these patients with the mental health provider who they may be seeing more frequently than the primary care. So why don't we use that opportune window to advance lung cancer screening engagement through a trusted provider in a trusted setting. And what we did in this tailored lung cancer screening educational intervention was both feasible and acceptable from all stakeholders, including patients. And then this survey and the post-intervention survey showed insignificantly increased concern about developing lung cancer, which is a motivator to get lung screening. The adapted educational material, for example, we had an original video of what to expect with lung screening. It didn't show like where patients safely storing their belongings, which is a concern for those experiencing paranoia. And the final video showed that the patient belongings were kept secure, that also the process was quick, didn't require any needles as well. So what is the road ahead? What is 2021 as we move forward and we think about return to care in a different way, so it's more equitable and inclusive of everyone. So the revised USPSTF criteria guideline really provides a great window for us to revamp our outreach efforts, particularly those that are underserved already. And then, but intentional outreach is needed for vulnerable populations. We cannot expect guidelines only to take care of the disparities that are existent without additional assistance that will promote equity in lung cancer screening. So when we look at, think about lung cancer screening interventions in the proposed model that we developed, for example, for the Latino community, when we think about promoters of lung cancer screening awareness at the patient, provider, and system level, we also think about opportunities for lung cancer screening. We think about promoters of participation of lung cancer screening. And then the outcome is increased lung cancer participation, either among Latinos or any other vulnerable patient population that you may think. So with that, I just want to say thank you for the opportunity to present today, and happy to take any questions along with Dr. Kazerooni.
Thank you so much, Dr. Flores. That was excellent. And I'm so glad that these topics got to go hand in hand. And there's been a lot of interest in regards to what you all have shared. The additional announcement I wanted to make about AMA that I forgot to mention, because we do get this question a lot, our online course that's on there is available to anyone, not only for free, but they do not have to be a physician. They do not have to be a member of AMA. And so we don't want that to be a concern for anyone. So feel free to take advantage of that. Just real quick, as far as the website is concerned for LUCA, you can find a lot more than just the webinar information and online course there. There's an extensive resource library, a lot of other events that we have coming up, and we're going to be doing podcast series. So please keep an eye and ear out for that, as well as technical assistance or resources you might like. Another way to keep up with us and current announcements on lung cancer topics in general would be following us on social media, whether that be Facebook, Twitter, Instagram, LinkedIn, even videos that we have that are very short on YouTube from our course. And for those who are interested, we do have stethoscope tags that really help the provider-patient relationship in terms of remembering about lung cancer screening and making patients who may not even be aware that lung cancer screening exists know that that's an option for them. And with so many things that typically need to be covered within one very rushed patient visit, it's really great if this is there, just letting the patient bring that topic up and ask if they might be eligible or qualified. And the same thing goes with posters that are demonstrated here on the wall that we can provide. So with that, I want to go back now to our Q&A. Q&A. I'll leave that there. And by the way, we have some other items too. So if you go to our resources page, you can order various tools that you might be interested in, and not just what I've been able to share now. And I also want to take the opportunity to say that Karen Combs with Luca is actually working behind the scenes with this event today, and is our communications and marketing coordinator, and really sorting a lot of these questions that you all are sending in. And so the chat is showing up for me now. And let me go back to some of the earlier ones that we've gotten. And if they've already been answered by you all somehow, Dr. Kazerooni or Flores, please let me know. But one of the things that was asked is, how do facilities typically know when payers will start covering based on these new recommendations? In other words, can you clarify when we might know that Medicare has finally approved these changes?
So for Medicare, it's very hard to predict the timeline. Their NCD request to reopen has already been accepted by Medicare to do so. Last time the USPSTF 2013 guideline came out at the very end of December 2013, and it was mid-February 2015 that their final NCD came out. So that was a little over a year. It was 13 and a half months. That's really the only benchmark timeline we have. Now that was a new coverage decision at the first time. They had no prior NCD to go on. So we're hoping that it will take less time, given that they already have a coverage decision that they're updating as opposed to starting from scratch. But we're going to keep our ears to the ground and see how quickly it will come along, and see if we can help them along as best we can. For private payers, it is pretty variable. They have the Affordable Care Act required timeline to follow. But like I've said, we've already heard of payers that are already making the change themselves. Reaching out, we are here in our area, we're working on a joint letter to send with some of our other health systems to our largest payers to try and get coverage done earlier. The American College of Radiology has put together a letter with some of its advocacy partners to send to the 5 largest national healthcare payers in the country, to also try and encourage them to do the same. So I think a lot of local advocacy is going to be required to make those changes earlier. But if you don't know if your payer is covering it, you can certainly reach out to your payer as an individual patient or as an institution to find out what's happening locally.
Yeah, that was a great explanation. Thank you. And we'll all do our part to try to get the word out. As soon as there's major coverage news, we'll put it out on social media. American College of Radiology will, National Lung Cancer Roundtable, everybody that can then help share that word, with hospitals and health systems will certainly do that. Next question says, any evidence regarding negative screens and when to repeat screening? Not sure.
So currently the recommendations for screening are annual screen. So if you have a negative screen today, you would have an annual screen in 12 months, assuming you have no abnormality and you're still eligible. If you have a positive screen, there are recommendations for interval testing, most of which is a low dose chest CT, and then returning to your annual screening.
Okay. Can you please discuss the discrepancy of the upper age limit of lung cancer screening? The 77 to 80.
I'm gonna pull my hair out on this one. This is something that I think we're all frustrated with. We have a USPSTF recommendation twice that now uses the age of 80. We know that many older individuals are diagnosed with lung cancer, and people are continue to live longer lives. So I think this is one that frustrates us. With the CMS coverage decision 77, we have encouraged them to address this in light of the guideline update.
And just wanted to quickly add to that, just briefly, not to the confusion, meaning that the discrepancy creates not only confusion from the provider perspective, but also on the patient perspective. And then that confusion will create an opening for some of the mistrust for those that are most vulnerable. So it's something to think about why policy, and when we're advocating, we try to be as consistent as possible so we can continue foster trust and people feel more comfortable receiving care and following recommended guidelines.
While I have you, Dr. Flores, the next question's for you. Can you speak to the importance of using a certified translator for printed materials versus relying on computer translations like Google Translate?
That's a great question. I think there are 2 things. One is that using a certified interpreter will help navigate some of the cultural nuances that happen with language that a computer will not be able to capture, but also relying fully on the computer, where it's going to be Google Translate, or even now, for example, Word has a capability to translate documents automatically. Having an interpreter be involved in the process will ensure that the documents are accurate and that they are providing the necessary information to make that health decision.
Great. Let's see. The next one I have is, let's see, from a little hard to read this at first. I know you have adjusted for many variables, but was there any adjustment or comparisons for socioeconomic status factors to determine if it's a truly higher based on race or access to care, poverty, et cetera, related to poorer lung cancer detection?
I mean, I think that that's a very it's a complex question. But I think when we look at barriers to care and how social determinants of health interact and influence outcome for our patients, it's a multifactorial combination that what it does, it results in poor outcomes because all of these barriers just pile on top of each other. So I'll make an example. A patient that may have limited English proficiency may have more difficulty getting a different type of job. Therefore, they may be working at minimum wage, and then it's difficult for them to get higher, an insurance that will provide coverage without out-of-pocket costs. Or they may have more difficulties working. They may need to work a couple of jobs to provide food on the table for them. So if we put all of those together, I don't want to oversimplify to one factor or the other. It's just that one, for many of these patients, there's a complex combination that unfortunately results in what we're seeing, that is a disproportionate utilization rates in lung cancer screening and other cancer screening modalities like such as breast and colorectal.
Sure. Okay. Thank you. Because we have so many, I'm just trying to fly through these. Let me know, Dr. Kazerooni, if this has already been answered, but it's indicated you might want to respond to this. Because insurance plans usually roll over January 1st, don't the insurance companies have until January 2023 to implement the changes? Thank you.
Yes, and I want to thank Angela Criswell from the GoTo Foundation, who is all over the coverage requirements and did make that clarification in one of her comments back as well. That is actually correct.
Both the ACR and CMS have long recommended the charge for a CT lung cancer screening should be the same as a diagnostic CT. This puts it way out of reach. Oh, let's see, it jumped on me. Puts it way out of reach, out of pocket patients. Could this recommendation be readdressed to suggest 71271 be set at a cost more palatable for patients?
Yeah, I think that's an interesting question. I think that's, information that we can send into our ACR colleagues. The setting of CPT codes and the amount of work effort that it takes. Sometimes people don't fully understand. A lung cancer screening CT is a chest CT. It covers the same part of the body from lower neck to the bottom of the lungs into the upper abdomen. So from a radiologist perspective, there's still the same amount of work effort to make sure the exam is appropriate, to make sure an appropriate radiation low dose protocol is being used versus a standard dose protocol and a standard exam. There's the same amount of anatomy to cover. There's still a report. And then there's the overhead of making sure that you're doing lung cancer screening as a population health measure safely, that you're reporting data into the registry. There's actually additional effort that's required for radiologists to practice lung cancer screening CT that doesn't happen with a basic chest CT examination. So the way billing codes and reimbursement are set is based on effort and work product. It's a simple way to answer that. And there may actually be more with lung cancer screening than standard chest CT.
Just wanted to briefly add to that. Dr. Kazerooni made an excellent point that lung cancer screening is more than just a CT. It's truly a program, and we can see here it requires registry participation, but there's also an educational component and a patient engagement as well, like what we're seeing here today with Luca. It's really hands-on and multidisciplinary, and so there's a lot of work behind each program.
Great. Okay, for the couple more that I think we can fit in considering, let's see. This person says, I have an oncologist that announced to everyone he will not order lung screenings until there is, quote, overall survival benefit data. I have reviewed the studies, but he wants to argue the benefit. Any suggestions?
I would suggest this individual referred to all the major professional society guidelines. We have an updated USPSTF guideline, which is recommending a lower payor and a lower age than before. We have an American Academy of Family Practice guideline, very stringent data analysis. We have a national comprehensive, if you're an oncologist in particular, look to the National Comprehensive Cancer Network guideline on lung cancer screening, which makes these positive recommendations. So the data is there, large numbers of your scientific colleagues recommend lung cancer screening and follow those recommendations.
Great, thank you. There were so many great questions here. I am so sorry we couldn't get to them all, but with having both of these very knowledgeable speakers, we'll make sure to get answers to those and get those sent out and/or on our LUCA website for you to get the answers that you would like, because there's a lot of great points brought up in here and never enough hours in the day for what we want to cover. So to finish here, I will just add that we really appreciate having your all's feedback. I believe I'm sharing my screen here, and I want to thank our sponsors, besides LUCA, of course, University of Louisville, and especially Bristol Myers Squibb Foundation for funding not only the overall project, but of course, including the event today. So with that, after this event officially ends, an evaluation prompt will come up immediately. So any other questions you have, please follow up with us. The information that's included here. This is, of course, information if you want to get further dialogue for health webinar offerings. And this is how you can reach LUCA, or specifically me, at the addresses and contact info listed with social media as well. So thank you all again. With that, we are right at 2:59. Appreciate your participation, and everybody have a wonderful day. Take care. Bye-bye.
Thank you so much.